كل شيء بدأ يوم وصلنا نايف للطوارئ وهو في غيبوبة بسبب نوبة صرع مستمرة. بعد ما شافوا أهله غرقان، في لحظات تحولت الطوارئ لسباق مع الزمن. بدينا مباشرة خطة الطوارئ العصبية بخطوات محسوبة تنفذ بدقة، كل ثانية منها تصنع الفرق في إنقاذ حياته.
This is my second visit to Al-Hassa, by the way, so I'm really happy to be here. So let's start without further ado, because this is a marathon of looking at the new guidelines and how that will change our look at how we resuscitate pediatric patients. So this is a mandatory slide that they told me that they have to put. I don't have anything to disclose except my love for this specialty and my belonging to the Saudi Society of Emergency Medicine. So our objectives are we're going to be setting the stage, we're going to be talk about pediatric basic life support updates, pediatric advanced life support updates, and the neonatal resuscitation updates. We're going to look at the system level, educational changes, practical implications for healthcare, and evidence and research behind the 2025 updates, and looking forward. So one trick that I'm going to do before we start, I want you to look at your fingers. And when you look at your fingers, please check your middle and ring finger. Are they the same size? No. If you have them the same size, please raise your hand because I'm going to refer you to Dr. Ibrahim Al-Alwan as endocrinology. Because it can never be that we have the same two fingers. Remember, these two fingers are what we're using for resuscitation of infants, right? So these two fingers are supposed to be the same size, otherwise you will not be able to really press very hard. So this is the first exercise. So let's go for it. We are sure for 100% that we have numbers, but unfortunately the Arab world as a whole, including Saudi Arabia, we don't have a lot of numbers related to out-of-hospital deaths and in-hospital deaths. We have them segregated into hospitals related rather than really a global look at the kingdom, okay? But our numbers are huge. So this is a 7,000 out of hospital and 20,000 in hospital pediatric cardiac arrest annually in the US. And I'm sure in the kingdom we have it higher than this, but because we don't have numbers. Please remember this formula, because if you remember this formula, this is the essence of all what we do. Survival is related to science, mastering the science of resuscitation, making sure that education is being done appropriately across the board, and then having a system that supports that. So if you have these three items, you are definitely going to succeed in having survival. All right? So let's look at the evidence. Among this evidence, the big event here that you see, this is how the people are looking at evidence and really criticizing evidence. But what I want you to concentrate on the level CLD, which is limited data. Because all our research in resuscitation, unfortunately, fits in that category. So that category practically looks at randomized or non-randomized observational or registry studies with the limitations of design or execution, meta-analysis of such studies, and physiological and mechanistic studies in human subjects. So limited data. Just concentrate on this one as the evidence, because most of the evidence that's coming out in 2025 is in that category. So at this point of time, that tells you how much of a lack of research that we are having. The lucky thing in 2025 that no longer we have an in-hospital chain of survival, an out-of-hospital chain of survival, whatever chain of survival, we unified it into one single chain of survival, which starts with the recognition and emergency activation, high-quality CPR, defibrillation, advanced resuscitation, post-cardiac arrest or acute care, and then recovery and rehabilitation, which was the new chain that was added. So in 2025, we say always every second counts. And that's what makes you successful. So if you plan your resuscitation right, and you make sure that you utilize every second of that resuscitation, your resuscitation will be successful. So let's look at the basics. When we look at the basics, we are still considering ventilation as an important issue related to pediatrics. So lay schools are strongly encouraged to provide rescue breaths in combination with chest compressions. Previously, we were concentrating on hands-only CPR for adults and for children. Now they came up with saying that no, ventilation in children are very important, especially opening the airway. So this is something that we need to look at. A dispatcher-assisted CPR is very important, and that's what the Saudi Red Crescent recently have started doing. So when you call them by 911, if you are in a arrest situation, they will guide you while you're opening your phone on speaker how to really resuscitate a patient. And the improved early intervention, telephone CPR instructions significantly improve the bystanders, and then there's critical for out-of-hospital care. Choking management has changed. Previously, if you notice, we have been using the infant, holding him in the hand, tapping on his back, then flipping him over, pushing in his abdomen. Now, no more abdomen. They said there is a sort of possibility that you may injure some organs. So now you press on the chest. Okay? And that's why the two fingers are important. So now it comes that, how am I going to press on the chest? Is it the two fingers that I'm going to use, or the palm of my hand? Okay? So now they changed them to a choking management to a new 5 blows and 5 thrust cycles on the children. That's how you do with the choke relief for the infant. The compression technique of infants now has changed. Instead of your 2 fingers, which are unequal, to a 2-thumb technique. So you hold your hands together and you press your 2 thumbs on the chest of the patient and between his breasts. And this way you have a support in the back, you have a support from the front, and you'll be able to know how much pressure you're pressing. And that's the new technique now that's standard for pediatric resuscitation across the board. Now, for older children, you still can use the 1-hand technique, not the 2-finger technique. So the 2-finger technique has been abolished. No more, we're not using it anymore. Okay? Now, for the PALS, there should be an early recognition and rapid support, focus on the respiratory failure and shock, definitely. And we know now that pediatrics are having more related respiratory arrests leading to cardiac causes rather than the cardiac causes having the cause. We need to continuously monitoring the work of breathing that we are having, tissue perfusion and mental status that enables early intervention before progression to full arrest. And then definitely vigilance through the look at the patient and monitoring. Now, one of the things that we added this year is something which is very impressive that we have been looking forward from 2022 to push forward, that this guidelines comes out forward. And that is the introduction of first epinephrine dose. Now, first epinephrine dose, though, if you notice, it is from 0 to 5 minutes. Before, it was really related to do CPR for 2 minutes, then give the epinephrine. Now, no longer. Now you can give epinephrine immediately if it's available during resuscitation. And don't delay. And that's one of the new things that have been introduced for the resuscitation and arrest conditions in children. Okay? So epinephrine timing, the refined protocol is earlier administration now recommended in non-shockable rhythms. Every minute matters for survival. The second additional that they put is that amiodarone became first line, remains the preferred antiarrhythmic for shock refractory ventricular arrhythmias with strong evidence support. Now, magnesium, there's new recommendation for Torsades de Bois and documented hypomagnesemia in pediatric patients that we need to give magnesium IV for improving the Torsades de Bois. The defibrillation dose energy dosing did not really much change. You start with 2 joules per kg, you go up to 4 joules per kg. You have to go even up to 10 joules per kg. So it's up to you where you stand and how fast you work with these patients. The introduction recently of the dual shock, what we call the dual shock for the refractory ventricular fibrillation, has been introduced as a new methodology that you can use, which is using 2 pads from the front and the back, and 2 pads from the upper left and the apex. And you shock them simultaneously. So that part has been introduced in the adult arena and in older children arena now for refractory ventricular fibrillation. So in the algorithm itself, for the pediatric cardiac arrest, the introduction are really in the red, so immediate epinephrine, ASAP, as fast as you can once you diagnose assistory and you start your CPR, and then again the shock as ASAB for pediatrics that has been really introduced recently for too. And that's what we here look for. Okay? All right. Now monitoring is very important. When we look at monitoring, they introduced the arterial blood pressure monitoring because of the consistency of the rhythm and the consistency of looking at the blood pressure. Now they're looking for a MAB of 60, MAB of 50, but they are more concerned about the diastolic blood pressure now. They want the diastolic blood pressure above 30, okay, above 30. They're looking also at the end-tidal CO2, and for the end-tidal CO2, they looked at an important issue. We have been using end-tidal CO2 for looking at return of spontaneous circulation, and that's correct, and we continue doing that, but the question is related to how much of that we're going to depend on. Because people have been prognosticating that if the ETCO2 is not increasing, then this patient is going to have a bad outcome. Recent studies have shown that the ETCO2 per se as a number does not indicate if this patient's survival is going to be high or low. But it does indicate if you are less than 30, if your ETCO2 is less than 30, there are 43% of that population have survived to out of hospital care with a normal health. So it doesn't necessarily mean that you have to go above 40 of ETCO2 to return spontaneous circulation, or that if it doesn't improve, then your survival is dependent on it. No, it doesn't show. So that's what the evidence is really looking for at this point of time. Okay. And airway management and bag mask ventilation is still preferable alternative to intubation. They have looked back at the evidence of, should we do intubation? Should we start with intubation first? And this is something that we have been looking for in pediatrics. We want to really intubate this child. We are resuscitating, we are really fed up. We're not sure if the ambo bagging is really doing a good job for the chest rising or not. This has really been now relooked at, and they discovered that there's no difference between patients who have been intubated and patients who have been done bag valve mask ventilation during resuscitation on survival outcome. So they still recognize that an effective and preferred alternative to immediate intubation in many pediatric cases, and the cuffed ED-tube is still the preferred, and again, they emphasize that there is no cricoid pressure is needed during intubation. The reason is that you block everywhere, and you block even the airway that you cannot see at this point of time. And the evidence around it is, again, as I said, CLD. So almost all the evidence here is not really, it's mostly observational studies, not randomized controlled studies that are looking for a big difference really in the field. And that's what they have looked at. So here in the last one, we found out that in a one small multi-center observational study of intubated patients found that ventilation rates at least 30 breaths per minute in children younger than 1 year of age, and at least 25 breaths per minute in older children were associated with improved rate of ROSC and survival to discharge. And here again, they iterate the issue that they have came out with in the last guidelines, that we raise up the respiratory rate to 1 every 2 to 3 seconds as a ventilation for patients. Okay. We reached to targeted temperature management, and in targeted temperature management, remember previously we used to say, okay, let's cool the patients down, cool the brain, reduce the metabolic rate, make sure that the brain recovers slowly rather than really leave him as is. The whole essence of the project is really to make sure that the patient does not develop fever. Because if the patient develops fever post-resuscitation, then your risk of reduced survival is really high. Okay? So they looked at the comatose infants in post-cardiac arrest, ages 24 hours to 18 years, and they looked to the first approach where the initial hypothermia at 32 to 34, followed by normothermia of 36. The option 2 is really maintaining normothermia at 36 to 37.5 alone throughout the post-arrest period, and the choice was based on institutional protocol, resources, and patient-specific factors. And it's not related if you have a refrigerator that produces ice. So it's just related to your resources in the ICU. Are you capable of maintaining that low temperature? And they discovered that there's no difference between them. And again, the evidence level is CLD. for both the target temperature and for the rest. So at this point of time, they recommend normothermia for pediatric patients. Extracorporeal, if you have noticed recently, we have been talking about ECMO for everybody. And we're looking for ECMO, especially during the last season of flu season, that we have had a lot of patients that require to go for the ICU. Unfortunately for pediatric ACRB, we have looked at the feasibility of this for pediatrics, and it has been a difficult task to really look at how we can resuscitate patients with ACRB. And again, the evidence is LD, and they say it may be considered for infants and children within hospital cardiac arrest, not out of hospital cardiac arrest yet. To conventional CPR and selective population in clinical settings with ECPR protocols and expertise. Now, the interesting part is that the evidence here lies on what? They are veno-arterial ECMO for refractory cardiac arrest, and that is very difficult to be done during resuscitation. Anyhow, so these patients should have had these lines installed in before arrest. And this is a very specific population that you're looking for. So when they did this, they looked at patients who have cardiac surgical, patients who had a cardiac arrest. So it was really a very specific population that they did the study on, and they looked at the observational here. So that recommendation is majorly related to the in-hospital cardiac arrest with a specific entity of patients, not all patients. So the recommendation at this point in time, not routine for out-of-hospital arrest. There's insufficient data that supports it, and to consider for select in-hospital cases related to cardiac surgical cases. The post-cardiac arrest care continues to be the same. The additional here data is really making sure that you don't do a prognostication on whatever data that you receive. You need to finish first, make sure that the ongoing critical care is being observed, make sure that the patient is under EEG, make sure that the patient is being done a coronary angiography if needs be, looking for the 5 H's and 5 P's, maintaining them. So those all are still post-cardiac arrest care zones, and they advise not to do really much of the prognostication. In newborns, the changes have really been majorly put in. Because they're looking at a 1% of the population of neonates that requires really much of resuscitation. So in the chain of survival here, they looked at the prevention. So prevention here goes back to the prenatal time, not only the time of delivery. No, prenatally they're looking at how can we prevent issues that comes out with the neonatal problems, recognition and activation, initial steps of recognition, ventilation, advanced resuscitation, postnatal care, and then recovery, again, as the same as the new chain that have been added to all the chains of survival. So now we have only 2 chains of survival that are available, the adult and pediatric chain of survival and the newborn chain of survival. And then they added them in the algorithm, and they put them forward the assessment of the antenatal care, the team briefing, and really looking at what's happening with the baby before they were born, and then looking at the algorithm as is. They looked at the gentle ventilation emphasis, oxygen administration guidance, and the thermal management as usual for the neonatal management. Debriefing has been added into the 2025 guidelines for all kind of providers, from EMS, rescuers, lay rescuers, healthcare providers, and the people who are working in the hospital. So they looked at the mental health support and the performance improvement categories. And they emphasized looking at how can you really improve the emotional and mental health support for the people who are really doing resuscitation. And they're trying to really look at how can we connect responders to rescuer, to the resources, normalize stress responses, provide emotional and processual opportunities, and reduce the psychological trauma and burnout. For performance improvement, they identify areas of protocol refinement, reinforce effective team behaviors, and create learning opportunities from real events and improve future resuscitation outcomes. Now, they emphasize the role of the team, and in here, the major part in the team addition is that the fixation of the person who's doing the monitor and the defibrillation to become the coach. So he is monitoring the person at the airway and person on the resuscitation on the CPR. So these three are the ones who are controlling the time that lapses during resuscitation, how much of the time that you stop the resuscitation before, and the improvement of resuscitation. So this is the additional part in the person who's doing the monitoring and defibrillation. So naloxone explicitly now has been included in the BLS guidelines, which is now introduced for patients who are suspected with opioid overdose. Drill escalation is very important, and people who have really looked at how can we do improvement in all the three domains: work of breathing, perfusion monitoring, and the mental status changes. On-scene resuscitation versus early transport. Now they have been changing to looking at doing more work in the field before you transport the patient safely. Feedback devices have had the class 1 recommendation that we came out in 2025 is that feedback devices have to be used during resuscitation. And this is very important to us. Gamification and rapid cycle deliberate practice. They introduced something new because the market now is really in the field of electronics. So they started looking at VR, looking at people who are doing games, and how can we improve the resuscitation through doing simulation with games and with VR. Visual reality and simulation has been introduced, and of course the future of resuscitation training has been really looking at this. They have looked at 760 recommendations, and among these you see that the class 1 strong recommendation is not really a lot of them. Most of them are really in the moderate and weak, which is the CLD type of recommendation. So let's look at the action steps. We need to look at updating protocol, training staff, audit performance, and refresh material. The take-home messages: high-quality cardiopulmonary resuscitation is the foundation of pediatric advanced life support, resuscitation for healthcare professionals, and we reaffirm the key components of high-quality CPR, providing adequate chest compression rate and depth, minimizing interruptions in CPR, allowing full chest recoil between compressions, and providing sufficient ventilation for the pediatric population. For initial non-shockable rhythms, administering epinephrine as soon as possible is associated with favorable outcomes for infants and children. Rapid defibrillation remains the priority for cardiac arrest with initial shockable rhythm. Administering epinephrine if defibrillation is not immediately possible. For patients who have, for infants and children with continuous invasive arterial blood pressure monitoring, diastolic blood pressure targeting more than or equal 25 in infants and more than or equal 30 in the children at least 1 year of age are now included as hemodynamic goals for high-quality cardiopulmonary resuscitation. End-tidal carbon dioxide can be an indicator of CPR quality, although the use of specific ADCO2 cutoff values to guide termination resuscitation in infants and children is not advised. Preventing hypothermia. Hyperthermia is a critical component of post-cardiac arrest care. Avoiding central temperature of more than 37.5 can improve neurological outcome in infants and children who remain comatose after resuscitation. For infants and children, new data supports maintaining post-cardiac arrest systolic and mean arterial blood pressure greater than the 10th percentile for age and sex. Neuroprognostication after cardiac arrest in infants and children requires multiple modalities be assessed at various time points throughout the post-cardiac arrest period. Single tests conducted in isolation carry a risk of inaccurately predicting neurological outcomes. And after discharge from the hospital, cardiac arrest survivors often have ongoing physical, cognitive, and behavioral challenges that require evaluation for appropriate therapies and intervention. The last one was the new data support the use of IV sotalol as an antiarrhythmic to treat infants and children with supraventricular tachycardia and cardiopulmonary compromise in cases where they are unresponsive to your usual ways and you don't have the availability of a cardiologist on board to help you and support you when you call them. And that's it. I thank you very much for listening to me.
Thank you so much.